want to welcome everyone. This is our inaugural PQAR Symposium. So this is the culmination of a fantastic first summer of our exciting summer program, Pipelines into Quantitative Research, sponsored generously by the National Institute on Aging. So we have an extremely talented and dedicated first cohort of 12 students coming from across the United States. And as Eric, Dr. Tchetgen Tchetgen was alluding to, they certainly persevered through very long days on Zoom and a very intensive schedule. And they did a really great job. They were engaged, they were curious, and they really learned, which is wonderful. So later today, we'll get to hear the results of their research projects, which will be wonderful. We're starting today with our keynote talk. So we have a renowned keynote speaker, Professor Tchetgen Tchetgen. Eric is the Luddy Family President's Distinguished Professor at the Wharton School of the University of Pennsylvania. So Eric is a brilliant statistician who has made fundamental contributions to the study of causal inference in observational studies. He's also unique, I think, in that he is also, in addition to the math and the statistics and the theory, he's also deeply dedicated to public health and has done extensive work on HIV in Africa, for example. He's also done work in aging, and for all of these reasons, he is perfect as our inaugural keynote speaker. And on a personal note, I want to mention that I've known Eric. I think I tried to nail down when I met you, but I think it was like 1999 or 1998. What summer was that?
Summer of '98.
98. Okay, so I've known Eric for.
I was a junior in college.
Okay, so he was a junior at Yale, and he came for.
I hope that doesn't give away my age.
or my age, or how much older I am. So he came to Harvard for the summer, and he was part of our early iteration of our summer program at Harvard School of Public Health. It was the 10-week version. And I was like loosely connected with Eric, and I didn't do very much for him. He didn't need very much. I do remember going with Eric to meet in a different professor's office, Donna Spiegelman's office, many times. And he did great work then, and obviously blossomed and did much more since then. So Eric, so I should say, formally speaking, so Eric was an undergraduate at Yale, and he came to Harvard School of Public Health Biostatistics and did his PhD there, and then was a faculty member at Harvard for several years. We were colleagues. And he left for University of Pennsylvania in 2018, the same year that I left. And Eric was a wonderful colleague and supporter of students and everything else. So I will end there, and thank you very much for joining us. And we look forward to hearing from you. So thank you.
Thank you so much, Rebecca. Let me share my screen. Okay. So thank you so much for such a warm and wonderful welcome and introduction, Professor Bitensky. It's a real pleasure, and this is very personal to me to be here today for all the reasons that Rebecca mentioned. And I wanted to make it have a personal note in my presentation. And so what I decided to do is, in fact, the first half of my presentation is basically just going to explain a little bit about my background and my unusual path to public health, and sort of how I got interested in and where my commitment to public health came from. And so I will have about half of my presentation talking about these personal notes and having some funny pictures of me when I was a kid and so on, just to illustrate how quirky I was. And then the second part of the discussion is going to be more about a scientific problem that I encountered a few years back that is still very much an important problem in aging research. And I picked this particular example because it's one that does not have a completely satisfactory solution to date. And it's one that Professor Betensky have made fundamental work in, the issue of truncation by death. And I will introduce and then use causal inference as a way of really articulating assumption and reasoning about how we think about bias in aging research. And so thank you again for this invitation. It's a great honor to participate in as a inaugural keynote speaker in Pipelines into Quantitative Aging Research summer program at NYU. So a little bit about myself. So I was born and raised in Cameroon. Those of you who are not familiar with Cameroon, here it is in red, the continent of Africa. It's bordered by Nigeria to the west, and in the north, Chad in the northeast, the Central African Republic to the east, and Equatorial Guinea, Gabon, and the Republic of the Congo to the south. Sometimes it's identified as being a West African countries and other times as a Central African country, depending on the situation and the benefit of being affiliated with one or the other region. It's a little complicated because there are currency issues, there are also geopolitical reasons for that. So it's not very large in terms of population, but it's moderate size, 25 million people. One of the things that I'm really proud about in Cameroon is it's very diverse society. We speak over 250 languages, and it's also diverse in its landscape. We have both access to the sea, as you can see, but we also have really mountainous regions and also tropical forests. So you get all of these, the richness in wildlife as well is reflected by this diversity. Where does Cameroon come from? The name Cameroon. So this is kind of showing the arbitrariness of names of African countries. Portuguese sailors happened to bump into the coast of Cameroon in the 15th century, and they noted an abundance of so-called ghost shrimp. And so these are these big shrimps that are really, really tasteful. Unfortunately, I can't really enjoy them because I'm one of the few Cameroonians who is allergic to ghost shrimp. This is in our main kind of Vuri River that the ocean fades into, and they therefore named it Rio dos Camareiros. And Camareiros means shrimp in Portuguese, and that eventually became Cameroon in English, the name of the country. So we named after a big shrimp, a large shrimp. Very, very strange. Nevertheless, these things happen historically. The country was subsequently a colony of Germany in the 19th century, and then it became a colony of France and the UK after World War I. And this is significant because part of the country is actually Anglophone, they speak English, and part of the country is Francophone, we speak French, as a kind of a remnant of this colonization. So I grew up speaking French primarily. I didn't grow up in the English-speaking part. So I had to learn English when I moved to the US, funny enough. And then it finally gained its independence in 1960, and has been Republic of Cameroon since then. So here's my family. These are my parents, and then my 3 older sisters. So I was blessed to have 3 older sisters, and they really took care of me and my younger brother. So that's me here, looking the funny-looking geeky kid. And don't be fooled by this picture. I was actually quite nutty as a kid. And I should explain my last name, because a lot of people, including editors of journals, think that it's a typo, the fact that my name is said twice, Tchetgen Tchetgen. But Tchetgen Tchetgen is actually my last name. And this is another peculiarity from Cameroon, that our names, if you're to be named Tchetgen Jr., the first boy is typically sometimes named Junior. And so our version of that is basically you say the last name of your father twice. And so that's how I inherited Tchetgen Tchetgen. All boys get two names. My brother is called Tchetgen Tchetgen. And I should point out that even though my mom forced a bow tie on my brother from a very early age, it never stuck. He now is kind of a vagabond poet slash philosopher slash computer scientist with dreadlocks. And so don't be fooled by these pictures. As I mentioned, I was incredibly nutty as a kid, though I somehow managed to maintain decent grades. And this got to the point where my parents asked me to choose between being sent to either military school or Jesuit school. They were done with me. I'm not going to go through all the bad things that I did or the naughty things that I did as a kid, but it really got to that point where they just needed me to be in an environment that emphasized discipline. And so at age 12, I was sent, which is really, really young. I wouldn't impose that on my kids these days, but at the time it wasn't unusual to go to boarding school. And so I obtained a scholarship to an all-boys Jesuit boarding school right outside of Paris in France. It's called École Saint-Martin de France. I have a picture here. It's a beautiful campus, and typical French campuses have these old castle-looking like buildings. And these were French monks who taught us in class for the most part. This was a hallmark of Saint-Martin. It was incredibly diverse. A lot of African students were offered scholarships to attend the school, and other developing countries as well. A very diverse student body. Which, as I mentioned, French Jesuit monks, and I put the French there in the sense that French Jesuit monks that may not be what you typically imagine monks to be like. They enjoy red wine for one and good cheese. The thing that really marked me about Saint-Martin is the incredible strong education, emphasis on education, which is also a hallmark of Jesuit education, is very well known for that. So I was very influenced from early age by this French Jesuit tradition in the role of and value of a good education, particularly with an emphasis on mathematics, science, and philosophy. Upon completing high school, I was presented with two options. I could either stay in France for university, or I could follow in my siblings' footsteps, who had all moved to the US, my three sisters, to attend university, and again, all through scholarships. The French education is very different from the American or education, in the sense that in French education, in high school, you already specialize in either in science and math, or in literature or philosophy, and it's very hard later on at university to change path. This is in contrast to US liberal arts tradition, which is ideal for someone like me at the time who was unsure about what to study. And so I opted to the US, and where I moved at the age of 18. So as an African student studying in the US, and any of you who might be an immigrant might also recognize this parent's pressure for me to choose between three professions, either be a lawyer, an engineer, or a doctor. I couldn't stand the sight of blood, nor could I argue compellingly for any cause, and so I decided to leverage my somewhat moderate skills in mathematics and the sciences, and opted for engineering. I eventually attended Yale in the early 90s as an undergraduate, where I studied electrical engineering. And something happened in my junior year. It was typical for Yaleys. I have a picture here of my college at Yale. It's Morse College, which is a little strange. It's modeled after an Italian. It's supposed to be modeled after an Italian old city. And what was really strange about you can't quite see it from the picture, but it has no right angle in the whole college. So it makes it somewhat easier to move in with furniture, if you had such furniture. But it was a very interesting experience to be there. A lot of undergraduates you might have considered doing so, take some time off. And so in my junior year, I took a year and a half off. I spent 9 months working at Coca-Cola as an electrical engineer staff in Atlanta. And I must say, I mean, Coca-Cola is kind of, it's one of the most well-known companies in the US, but that experience was not particularly enjoyable for me. And so after that, I applied for a grant to go to Ghana. And I lived in Accra, Ghana, with a summer grant to study determinants of adoption of new technologies by farmers. And so this was somewhat related to engineering, but not quite engineering, and bordering social sciences. And what happened during as I said, during my experience at Coca-Cola, I realized that engineering was not a good fit for me. I had some, I was quite shocked by certain facts that I learned. For instance, I learned that the most remote areas throughout Africa, including Cameroon, where in fact WHO vaccination programs for kids, inoculation programs for kids, had to, in fact, where it was really hard to access them. Nevertheless, they could hitch a hike on Coca-Cola delivery trucks. And that basically means that Coca-Cola had access to the most remote areas to sell these beverage, sugar-based beverages. And whereas organizations that were trying to act on public health did not have such access. And so that made me realize that I cared more about public health than perhaps making Coca-Cola or any other related engineering task. And so this experience in Ghana was formative, as I learned through my research that Ghanaian farmers, in fact, prioritize their health and that of their families. This was one of the outcomes of that research project, over adopting new farming technologies. And this was my first foray, as I said, into public health. And so upon my return to the US, I looked up professions at the intersection of mathematics and public health, and I discovered biostatistics. It was early days of the internet, and so that served me well. And my first formal introduction to biostatistics, as Professor Botensky mentioned, was through a program similar to the pipeline program you're currently participating in as a summer intern. It was an incredibly fulfilling experience. I was really fortunate to be paired with Professors Botensky and Spiegelman at HSPH, the Harvard School of Public Health, working on analysis of correlates of condom use in Tanzania in the context of a raging HIV epidemic. During the summer program, I fell in love with biostatistics. I applied to a single PhD program because I decided that's what I wanted to do as a career, and I really just love Harvard so much that if I did not get in, I would just keep applying until I got in. So I applied once and fortunate to get in, and then I completed my doctoral degree and a postdoc under a mentorship of Professor James Robbins, who is also a peculiar individual in the sense that he's self-taught statistician and epidemiologist, and is renowned as one of the founders of the modern field of causal inference. Let me say a little bit about faculty jobs. Some of you may be interested in potentially being faculty, and I just want to talk a little bit about my experience as a junior faculty. I first started as an assistant professor of epidemiology at HSPH, eventually joined biostatistics as my primary appointment, and then was eventually had joint appointments. Being a faculty was a steep learning curve there. I learned that to be a successful academic, you must strike a balance between teaching responsibilities, mentoring students and postdocs, building collaborations and research agenda, promoting your work through speaking engagements and conferences, writing and submitting grants to support your research interest. Other lessons from junior faculty years, which have served me well, I think, still today. Good mentorship is priceless. So as a junior faculty, I actually sought out mentorship from more senior faculty. And I learned that everyone needs it, particularly in early career stages. And so this is it's really invaluable. And I think one should really embrace this idea of seeking mentorship, either as a sounding board or other kinds of advice. And what you'll find is that senior faculty and as well as folks in the administration are usually really receptive and welcoming of such requests of mentorship. The other thing that I learned is that collaboration is the building block for good science, particularly in public health. Faculty in the sciences essentially function as entrepreneurs whose driving force is generally not financial gain, although financing is key to success because you need to be able to fund your research. The last thing that I learned, and which I'm particularly passionate about, is service to our profession. So service to your profession, conference planning, editorial work, community work, things that do not necessarily are not necessarily required by the job, but one volunteers to do. This is incredibly important in formative years and even later on. It's not only good for one's profession, but also creates opportunities to network which invariably leads to unforeseen opportunities. In my own experience, this type of networking has led me to teach and visit colleagues around the world, including the countries given here. Until today, well, except for the pandemic, I now do it online. I was teaching a course in China last week online, which is not quite the same experience as being there in person, but still allows for this possibility to network with younger folks in statistics. Let me talk a little bit about as a segue into the scientific. We're about halfway through the presentation. Aspect of this talk. So my primary research area, as Professor Bitensky mentioned, is in causal inference and semi-parametric theory. And roughly speaking, causal inference is a discipline on scientific discipline to understand and learn how to infer from data the causal effect of potential interventions on health outcomes of interest. You might very early on during the COVID pandemic, we had candidate vaccines for COVID, and the causal question was then, if we were to inoculate the whole population, would we reduce and eventually vanquish COVID, versus if we're not to inoculate them with a particular vaccine candidate. And so that is a causal question. We imagine that we have intervention in mind, and we have to think scientifically about study design to answer that causal question. So causal inference is kind of the discipline that articulates assumption and it provides the tools to reason about potential sources of bias in trying to make such inferences. And then it's nicely combined with semi-parametric theory, which is more of a statistical idea, and essentially how to learn from data without making unnecessary assumptions about mechanisms that generated the data. And so you might be interested in a particular effect, the causal effect of a vaccine on preventing serious illness with COVID vaccine, with COVID. And so the question is, under a given study design, how best to make use and identify and estimate that effect without making unrealistic assumptions about the observed data distribution, particularly with infectious diseases. As we know, it's infectious, so people are not, you don't necessarily have an ID sample in the sense that people might be connected and might be transmitting the infection to one another. And so you need to account for that. And so semi-parametric theory allows you to get rid of a lot of these assumptions, not all of them, but a lot of them, and make inferences. And so I was attracted to such theory for that reason. And causal inference and semi-parametric theory have given me an opportunity to collaborate with researchers in several disciplines where causal inference plays a crucial role. And this has happened over the years, including in HIV epidemiology, as Professor Bitensky mentioned. Environmental health, the impact of air pollution is something that I really do care deeply about. Infectious diseases as well, genetic epidemiology, and the topic I want to discuss today, Alzheimer's disease and related disorders in aging research. And so, as a vignette of causal challenges in causal inference challenges in aging research, I thought I would discuss two examples that I've encountered. One early example, which was concerned with selective attrition due to mortality in aging study, where we were interested in the causal effect of smoking on disease progression, measured through measurements of cognitive decline over the years as evidence of potential dementia. And a puzzling, the second example, which I will cover very briefly because this is something that I'm planning to do and that was recently funded. I'm really excited about tackling this problem, and they're connected. And it's about a puzzling relationship between blood pressure and Alzheimer's disease. So those are the two examples that I hope I'll have enough time to cover. So I'll talk more deeply about the first example because this is an analysis that we've already completed and published. And so most studies in epidemiology of aging typically involve follow-up of aging population, naturally. When, as in Alzheimer's disease and related disorders, the outcome of interest is disease diagnosis or progression. Individuals in such aging population may die before the outcome is fully observed. Thus, for such individuals, it is said that the outcome of primary interest is subject to so-called truncation by death, because by virtue of being dead, the outcome is not well defined at the post-death. And that is, the outcome is only observed for participants who remain alive long enough to experience the outcome. And so you inherently, implicitly conditioning on survival. You must be alive for us to observe the outcome. And the issue is, does that conditioning event, does that looking only among survivors, does that induce a survival bias? And can we measure it? Can we account for it? Can we correct for it in our analysis? And so truncation by death threatens our ability to learn the potential impact of modifiable risk factors for dementia and associated symptoms. And this is because selection bias from selective mortality and other forms of attrition, such as people, if you have a follow-up study, people may be dropping out over time for other reasons than death, just because of potentially morbidity. Such selection will bias estimates of risk factors associations with an outcome if selection is influenced by both the risk factor and the outcome of interest. And that's because eventually those people who remain alive or remain in your study are in your study and alive basically because they're healthier than the people who died earlier. And so you might be having a really substantially more robust population to the elements of dementia and related ailments, and might not be able to really identify what you're interested in, which is the impact of modifiable risk factors on progression of disease. This form of bias is known in causal inference as collider stratification bias, and is represented graphically as shown in the following slide. So I want to talk a little bit about why is this structure that you have in your data, in the data that we collect for these types of studies, why is it subject to this form of selection bias, collider bias? Collider bias is represented here in this graph, where this is known as a directed acidic graph. Think of the variables. So I have an underlying risk factor. Later on, that will be smoking behavior at baseline. When we enroll patients, then we follow them over time. Some people die as we follow them over time, and some people survive. And among the people who survive, we measure an outcome. In this case, it will be cognitive decline over time, or cognitive function measured over time through some cognitive instruments that people use. U here is going to denote an unmeasured common cause of survival and the outcome. Genetic factors, for instance, could be one such source of confounding, but it could also be intermediate cognitive decline. So prior to measuring your cognitive decline and the follow-up, we measure your cognitive decline throughout the study, and that could in turn cause the outcome and your ability to stay alive. Okay, so collider bias, represented here for an arbitrary risk factors, induces a spurious association between the risk factor and the outcome, even when the risk factor does not have a direct effect on the outcome. And so if you look at the graph here, the arrows are meant to reflect causal effects. So the risk factor is a cause of survival. Smoking does cause you to die earlier than if you did not smoke. And what I've included here is I'm drawing the diagram just to emphasize on this selection bias. I do not have an arrow from the risk factor to the outcome. So I'm assuming here that the risk factor does not cause cognitive decline. And this is a useful thing to do when you're trying to reason about bias, to first assume that there is no causal effect. And this is because as public health people, we're incredibly conservative. We want to know if there's actually nothing going on, can we make sure that we recover the right answer? And certainly if you can't do it there, you can't do it if there's actually something going on. And so this is one such graph where I'm assuming the null, that there's no direct effect of the risk factor on the outcome of interest. And what happens here in depicting the graph by this box is that in my observed data, in my observed sample, I'm conditioning on those people who survive. And that's what the box means. This induces a form of collider bias in the following sense. So to understand this phenomenon, collider bias, conditional on only looking at data among people who survive, is going to create an association between the risk factor and the outcome, even though there is no causal association. And this association is through this pathway, okay, from risk factor to survival to the genetic factor that also causes the outcome. And that is not a causal association. And that's because the graphical structure here of these two arrow meeting at survival, the fact that the risk factor predicts survival and the genetic factor predicts survival, is what's known in graphical language as a collider. The two arrows collide. And colliders, if you do not condition on them, do not allow probability or association to flow. So unconditionally, the risk factor and the genetic factor will be independent of population, but upon looking in the survivors, they become correlated. And so this is known as collider bias, that to understand this phenomenon, suppose that both the risk factor of interest and an unmeasured genetic factor U are protective of survival. And so participants with the risk factor are more likely to survive, and then participants without the risk factor, and likewise participants with the genetic factor you turned on are more likely to survive than participants without the genetic factor. And so I've kind of reversed the association here to be protective just for the sake of illustration. And so what happens is, suppose that in a population, these two factors are independent of each other, okay? That is, as depicted in the graph, if I did not condition on the collider in a population, I just look at is the risk factor associated with the genetic factor, and it turns out that they're independent of each other in the underlying population. That is, having U turned on, it's not at all predictive of being exposed to the risk factor. So knowing something about the genetic factor does not predict anything about the risk factor. Now, suppose that we observe the outcome on a person still alive. And so we're now explicitly conditioned on survival. And we learn that such a person does not have the genetic risk factor U turned on. What can we conclude about the person's genetic, I think I reversed the order here, I apologize. So suppose that such a person does not have the risk factor, not the genetic risk factor, the risk factor turned on. Okay, so I apologize, this is a typo. So we're looking at among people who survive, and we look at their risk factor, in this case, smoking, whether or not you're not a smoker. And we note that for a given person who's alive, they're a smoker. Okay, so what does that tell us? What can we conclude about the person's genetic risk factor? Well, because the person is still alive, and we know that both factors are protective in this case, not having the risk factor turned on means that the person is more likely to have the genetic factor turned on than not. And so, though these two factors in the population were independent of each other, by stratifying only on survivors, they become associated. And that's a spurious association. It has nothing to do with the underlying probability distribution of these two factors in the whole population. And this is what we refer to as a spurious association due to selection bias or collider stratification bias. In plain English, conditioning on being alive renders two factors that are independent in the population negatively associated in the steady sample of survivors. As the genetic risk factor is also associated with the outcome, so the genetic factor is also associated with the outcome, this implies a spurious association between the risk factor and the outcome through this pathway that you've now created, which is not a causal pathway, when in fact there is no causal relation between the two. This phenomenon will therefore bias the relationship between the risk factor and the outcome, whether or not their causal relationship is present, which we refer to as selection bias. And so this is a crash course. Now you understand selection bias and why it's an issue in Asian research as far as survival bias goes. Now let's turn to smoking. So smoking is generally thought to increase the risk of cognitive decline and dementia in older age, mainly through its well-established vascular effects, although some data suggest potential benefits of nicotine among light and moderate smokers. In fact, Findings from longitudinal studies of smoking on cognitive decline have been mixed. Some found that it's protective, some found that it's harmful. So we're curious about this potential reversal of the effect. One issue that was also reported in all of these studies was that, as typical in longitudinal studies of older adults, a substantial proportion of baseline populations were lost to attrition during the study, either due to mortality or dropout. Several of these studies also reported a strong association between smoking history and attrition. In fact, smokers had between 2 to 3 times the mortality of never smokers in those studies. Thus, these studies may have underestimated the adverse relation of smoking to cognitive impairment, because essentially those people who were affected by this effect were killed off prior to the outcome of interest being measured. And so you have a very highly selective subpopulation on which you're running your analysis, and that tends to underestimate the causal effect of interest. In fact, we have the following graph. This is exactly the graph that I had before, but now I've made explicit what the risk factor of interest is smoking. It's something that we can intervene on. It's a risk factor that's modifiable. And the hope is that if we could reduce the rate of smoking, we might be able to positively impact the cognitive decline in aging population. So in fact, we have the following graph encoding survival bias as potential explanation for attenuation or apparent reversal of smoking effects on cognitive decline. And to understand the sign of it, you basically have to recognize that smoking is negatively correlated with survival. People who smoke are more likely to die early than people who don't. And prior cognitive decline is also highly correlated with dying. And so you get this negative association. Previous cognitive decline is positively associated with further cognitive decline. And so when you do the calculus of collider bias, in fact, what this would imply is that in fact you would find that the effect of smoking on cognitive decline, conditional on survival, will be severely attenuated and possibly reversed. So you might look at this association and you might find a protective association of smoking with cognitive decline, when in fact there is either no association, or in fact smoking is harmful as suspected with respect to cognitive decline. And so a common approach in regression models of the association between smoking and cognitive decline is to try to adjust for these factors that predict attrition. But that actually causes more problems than resolves them. This approach is in fact unsatisfactory, as predictors may be on the causal pathways of smoking. Prior cognitive decline may have been as a result of your past smoking behavior. And so adjusting for a variable that is post-exposure can in fact bias effect estimates and can amplify the selection bias. And so that is not a solution. Regression adjustment is not a solution in this situation. Okay, and so this is what I say here. For example, prior cognitive function is a strong predictor of both attrition and future cognitive decline. Adjusting for it using standard regression analysis, which you might have been exposed to during your time here in the pipeline program. In this particular case, it's not an adequate solution. It could produce estimates that are substantially inflated and possibly reversed. And so we wanted to demonstrate this phenomenon using an actual study. We used data with collaborators from the Chicago Health and Aging Project, a sample of a little over 2,700 people. We aim to quantify the extent to which survival bias and other sources of attrition might distort the association between smoking history and cognitive decline. And our paper was, Jennifer Weave was the first author of this paper. And I provided the support for the causal analysis and coded up the analysis. Participants, so this is one of the, Jennifer is an epidemiologist in aging, the study of aging. And this is the kind of collaboration that I've been talking about that has really been valuable in terms of using statistics to further understanding of public health interventions. So participants were aged, in the study were aged between 65 and 109 years. They were current smoker or never smokers that underwent cognitive assessments up to 5 times at 3-year intervals over a period of 12 years. So 4 measurements, a baseline and 3 follow-up, a maximum of 3 follow-up. The study was subject to a lot of attrition. By the end of the study, only 20% of the cohort remained in the study. So 80% either died or dropped out. And 68%, basically close to 70% of the attrition was due to mortality. So this is a pretty old population. And so the kind of selection bias I was referring to earlier is a particular concern in this study, because you're left up with 20% of the sample by the end of the study. And so the question is, how do we address this potential for strong selection bias due to survival and other sources of attrition? I apologize that the font is small here, but hopefully this is not on a screen, but it's on your computer, so you could maybe do what I'm doing and get closer so you can actually see the numbers. So this table provides is a table of the association between risk factors, including smoking at baseline, the exposure of interest, on attrition. And I have 2 kinds of attrition, and this is a hazard ratio. You can think of it as a risk ratio. The probability that you die, divided, given that you're a smoker, divided by the probability that you die, given that you're not a smoker, at each point in time of the follow-up, conditional on having made it up to then. So that's what a hazard is. You can think of it as the risk of dying, essentially. And so having a hazard ratio greater than 1 means that the smoking increases your chances of dying, which we know it basically essentially doubles your chance of dying in this sample. And also, interestingly enough, it reduces your chances of attrition due to other causes of dropping out. Okay. The other interesting variable that I want to emphasize here is cognitive score prior to the time point. At each time point, we look at your prior cognitive score. And so this is playing the role of a common cause of attrition or death and future cognitive score. And we see that it's strongly associated with attrition due to death and attrition due to other causes. Okay, and so this is exactly the situation that we were worried about, that we have both the exposure of interest, smoking, is a strong predictor of attrition, and we have risk factors that are post-exposure that are strong predictors of attrition, and we know also strong predictors of future cognitive decline. Okay, and there were other factors that we accounted for. I'm going to skip over them in the interest of time. This is enough to know that we have a problem. You cannot ignore attrition and simply look at the analysis associating smoking behavior on cognitive decline among those who survive. That will be a distorted analysis. So because prior cognitive score or cognitive decline is causally affected by smoking history, adjusting for it in a regression model, as I said, is likely to amplify selection bias and not reduce it. Instead, we propose a so-called inverse probability weighting method to account for attrition-related selection, which I'm going to explain now conceptually. We first model the probability of continuing the study, being alive and not otherwise censored, given smoking status, baseline covariates, and time-varying covariates that were in that table that I presented in the previous slide. We then use these probabilities to compute analytically weights that are in inverse proportion to the probability of remaining alive in the study. So what does this do? Why is this a good idea? Well, essentially, to understand what's going on is that observations with characteristics associated with lower probability of continuation, example, physical frailty, which evolves over time, were essentially assigned a larger weight, essentially compensating for the underrepresentation of these types of observations. So people who have a very low probability of survival were upweighted. If they still survived, but we computed that in fact, they were otherwise would not have survived with high probability. We took that probability and we upweight them by dividing it by the survival probability. And this compensates for the underrepresentation of these types of observation in the observed follow-up time. And so to further ground this idea, let me give you an example. Suppose I have a survivor with characteristics that determine she had a 1 in 10 chance probability of being alive at a particular time, follow-up time. That person would be upweighted by 10. So they will count for themselves. They made it. They're the 1 in 10 people who made it. And that person, she will also count for the 9 people that are missing by virtue of them missing with probability 9 over 10. And so this person is upweighted to represent the fact that there are a lot of people like her who had a very high probability of dying. And so we upweight her to reconstitute the population if we have been able to, this is a big word, but to prevent their death by some intervention. And so this essentially gets rid of the selection bias, because over time, as people die, we essentially revive them analytically to create a balance and get rid of this attrition process. Now, some are critical of this idea of reviving people. This is kind of just an exaggeration of it, obviously. It's analytical. It's just to picture what exactly this reweighting does, what it's doing in the sample, in your analysis. And so we then apply the weights to analyses of the association between smoking and cognitive decline. Intuitively, the reweighting thus effectively removes the association between baseline and time-varying factors, common causes of cognitive decline and survival, including smoking, therefore eliminating any selection bias due to selective attrition driven by these factors. Importantly, the causal effect of smoking on cognitive decline is left completely untouched, unaltered by this reweighting operation. And so we've essentially created a study in which, a pseudo study in which everything else is the same in terms of the outcome distribution, but we've gotten rid of this selection phenomenon. Okay. It is also important to emphasize that in order to completely eliminate selection bias using this approach, it must be assumed that all common causes of the outcome and attrition are observed, an assumption that is implicitly untestable empirically without a different assumption. So I don't have time to get into how we might be able to assess the extent to which this assumption might hold, but there are methods available that my group has developed and as well as other groups have. The weighted analysis eliminates significant amount of attrition related to selection bias, which severely underestimates the causal effect of smoking on cognitive decline. And as shown here in this table, I want you to focus on this difference. This is a difference comparing the change in scores in cognitive change, the difference in cognitive score change during a period of 10 years, comparing current smokers to never smokers. And so the negative sign means that the cognitive score is declining, which you expect. The unweighted analysis suggests that it's declining by 10 points essentially over time, over that period of time. Whereas the weighted analysis, we had 2 of them, essentially suggests a doubling of that rate. That in reality, the selection bias is suggesting a much slower decline due to smoking than if you correct it for the selection bias. Okay, and so this is a really important point, is that a lot of the aging studies may be underestimating the impact of some of these modifiable intervention, and sometimes actually suggesting a reversal of the effect. There are important limitations to analysis, which I think it's important to discuss in this context. We did not address attrition prior to enrollment of the study. These participants were enrolled later on in life, and this is known as left truncation, another area of statistics that Professor Betensky is a world expert in. In a study that begins when participants have already reached advanced age, mortality and debilitating morbidity related to smoking and cognitive function have occurred prior to study enrollment, leaving a study population already differentially selected. And there are ways to investigate this. In fact, there's a published meta-analysis of cohort studies that had enrollment at different ages and looking at the association of smoking and dementia, incidence of dementia. And they found that relative risks tended to be smaller in studies whose participants were enrolled at older ages. And so this age of enrollment is an important factor that we were unable to account for. And a way to account for it is essentially to do a meta-analysis where you have studies that enroll patients at different ages. What we were able to do is that we had patients enrolling at different ages in our study. So we were able to mimic this meta-analysis in our study. So indeed, unweighted analysis in the CHAP data that I reported, stratified by age at enrollment, yielded a declining association between smoking and cognitive decline with increasing age at enrollment. And so this is reflective of this idea of that left truncation may also be at play here, which we have not addressed at all. And so this, though we have corrected the effect upward, there may be further, this may only be a lower bound of the actual effect of smoking. Many people who smoked at baseline quit during the follow-up. So some people were classified as smokers when in fact, eventually they were former smokers at follow-up. And so if cessation is more likely with poor cognition, then the use of baseline smoking actually remediates this source of bias. So this alleviates the concerns of that. It's kind of in the same spirit as an intent to treat analysis if you're familiar with it. In principle, one could use time-varying smoking status as an exposure. However, this would require measuring determinants of quitting or initiating smoking over time, which is far more challenging than the data was available in our study. Okay, so I do have maybe about, I think, 10 or so minutes left. I want to leave some time for questions, so I only have 2 more slides to cover or so. And so I wanted to talk about another peculiar relationship between blood pressure and Alzheimer's disease that was recently reported. I do want to talk about this because I'm only briefly, I haven't actually finished the analyses, and I want to explain the rationale for trying to reanalyze this data. So selection bias may also play an important role in recent analysis suggesting counterintuitive findings such as a protective effect of elevated blood pressure, high blood pressure, on the risk of Alzheimer's disease. In fact, this recent paper found that genetically predicted higher systolic blood pressure was associated with lower Alzheimer's disease risk with an odds ratio, which is essentially 25% lower than those who had normal blood pressure, and a very strong p-value. And so this was pretty strong evidence suggesting that that this association was real. This analysis was based on something that I didn't really talk about today. It's a really growing type of study design to address confounding in aging, Mendelian randomization studies, which essentially leverage the fact that genotypes are randomly assorted at meiosis and are thus independent of conventional confounding factors and the disease progression. And so what people do then is, if they're interested in the causal effect of blood pressure on Alzheimer's disease, rather than using observational data and using the observed systolic blood pressure, what they do is they look at so-called genome-wide association studies. And these are studies that try to find the genetic determinants of a variety of phenotypes. So they look at GWAS studies of systolic blood pressure. They identify the genes. And because genes are assigned randomly during meiosis, essentially, they effectively can instrument, terminology here, that essentially means rather than using your actual blood pressure, they use the blood pressure that's predicted by your genes. And what that does is essentially, because it's the blood pressure that's predicted by your genes, the component of your blood pressure that's actually due to your genetic makeup, and genetic makeup is randomized, this is as close as randomized, just by leveraging biology. So this is a really popular method of analysis growing in epidemiology called Mendelian randomization. Mendel is this idea of assortment at meiosis due to Mendel, the name Mendelian, and randomization is also connected to that idea. And so they did this analysis, however, and they found this relationship between blood pressure and Alzheimer's disease. And I had to concern about this. And so I wrote a grant and I submitted to the NIA, the National Institute of Aging, and it recently got funded. And we hypothesized that this finding may be subject to survival bias similar to that described in the smoking analysis we conducted, and that inverse parity weighted may help reduce selection bias. There's another aspect of this that makes it really interesting, is that the story that I gave you about Mendelian randomization, it was somewhat incomplete in the following sense. Mendelian randomization makes a key assumption that the causal genes for blood pressure are associated with Alzheimer's disease, which is downstream of blood pressure, only through the effects mediated by blood pressure. That those SNPs, those genes, the genetic determinants of blood pressure, cannot affect Alzheimer's disease diagnosis other than through your blood pressure. This is a really strong assumption. This would rule out any other pathway between such genes and Alzheimer's disease not mediated by blood pressure. There is no theoretical nor empirical basis justifying this assumption. In fact, genes involved in Alzheimer's disease are well known to be suspected to be so through complex network of pathways, a phenomenon known as theotropy in genetics, which would invalidate this assumption. This assumption is sometimes referred to as an exclusion restriction. And so in this genetics use, the use of genetic markers as candidates for Mendelian randomization suffers from this weakness. And in fact, this is a serious weakness because it's not testable from the observed data without making a different assumption. So what we've done is we've recently, with support from NIA, we've developed an MR technique, aptly named MR Genius, Mr. Genius. It's a little bit of an obnoxious name, but that's kind of the field of Mendelian randomization. Everyone has a catchy name, and so we wanted to end the debate about the best or the worst catchy name, and so we came up with this acronym, Mr. Genius, and which stands for G estimation under no interaction with unmeasured selection, which I could explain, but we don't have the time to get into what every single of these terms means. And the thing to highlight with this method is that it's robust to violation of the exact assumption that I just described. It does make a different assumption that I could discuss if people are interested a little later on, which we believe is actually a testable assumption. And so you can assess the extent to which MR Genius might be useful in a particular in this particular application. And so stay tuned for these analyses, which was, as I mentioned, recently funded by NIA. And so I think I hope I have demonstrated that statistics combined with causal inference can effectively be a useful tool to reason about potential sources of bias and correct for those sources of bias in aging studies, in particular in these relationship between smoking and cognitive decline and dementia and blood pressure and Alzheimer's disease. So my last slide is one of acknowledgement. I want to thank my collaborators who made this research possible. Jennifer Weave and Maria Gilmore are the two epidemiologists I work closely with who teach me about aging research, which is not my training, but I've learned a lot through the years working with them. Stephen Walter is another fellow epidemiologist who I've worked with, and Bao Sun, who used to be my postdoc and now a faculty in Singapore, National University of Singapore, with whom I have the genius work that I mentioned, the genius method that I mentioned. It sounds so obnoxious whenever I say it. We work together on this work. My research is funded by, I've been fortunate to have currently have funding from NIAID doing work on HIV, NCI doing work on cancer, NIGMS doing work on infectious diseases and study design, in fact, for COVID. And then the work that I described today funded by NIA. And these are two references among the references that I mentioned that point to the work that I did. That was the basis of this talk, the Genius paper, which is in press at Statistical Science, and the paper whose result I presented on the correcting for selection bias due to attrition in examining the effect of smoking on cognitive decline. And I will stop here. Thank you so much for your attention.
So thank you again, Eric, and thank you everybody for joining for this morning.
Thank you so much.